Hello everyone and welcome to another video of Lectures MD on YouTube. Now this time we're going to talk about multiple sclerosis. Now multiple sclerosis is an inflammatory disease of the central nervous system. It's a demyelinating disease. Exactly like Guillain-Barré is an inflammatory demyelinating disease. But the difference between multiple sclerosis and Guillain-Barré syndrome is that multiple sclerosis always hits the central nervous system. On the contrary, Guillain-Barré hits the peripheral nervous system. So we're going to start with multiple sclerosis. Now, multiple sclerosis is an important cause of long-term disability in adults, especially in the United Kingdom, where the prevalence is approximately 120 per 100,000. The annual incidence is around 7 per 100,000, while the lifetime risk of developing MS is about 1 in 400. The incidence of MS is higher in Northern Europeans and the disease is twice as common in females. Diagnosis of MS requires the demonstration of otherwise unexplained CNS lesions separated in time and space. Now, what does this mean? This means that if you only have a new episode of neurological manifestation of some disease, you can't initially say this is MS. The term that is used initially when you experience unexplained clinical manifestation of neurological problem is clinically isolated syndrome. Now, because MS requires a separation in time and space, which means that the lesion must be in at least two positions in the central nervous system, and it must be separated in time. You can't have the two lesions in the central nervous system at the same time. This is not MS. MS needs separation in time and space. There's a criteria to diagnose MS. I will link it below. I will link it in the next slide, but for now, you should know that MS needs separation in time and space. Now, this is the first thing you need to know. The other thing you need to know, there are exceptions in which you can diagnose MS with only at the first clinical isolated syndrome, but this needs another criteria. I will link it in the next. Have initial relapsing and remitting clinical course with variable intervening recovery. Now, MS has, let's say, several courses or prognosis courses. The first is relapsing and remitting course, which means that the patient will have an episode and then he'll slowly heal, and after that another deficit, another clinical deficit, and then deficit will heal. But the healing is complete. So you'll have, say, hand will be paralyzed, and then he will regain some of the power of his hand, but he won't be able to regain the whole power of the hand, the whole function of his hand. And then his leg will start to become paralyzed, and then he will heal a little bit, and so on. So this is relapsing and remitting course. The other course is primary progressive. Primary progressive means that the patient starts at a certain level with his first clinical manifestation and goes on gradually until he's dead, or until the patient is dead. Uh, there's secondary progressive, which means the patient starts as a relapsing and remitting course and then goes on to develop a secondary progressive MS, which means that at certain point in his relapsing and remitting course, the patient will start to develop more and more symptoms without regaining new function of already injured neurons. And there's a form of primary progressive, which is fulminant. It's the same, but it's very fast that patients are expected to die very soon after the first presentation. And there's another presentation where one attack is not followed by any other attack of MS. And this usually happens, or especially happens, if the first presentation is optic neuritis. If the first manifestation is optic neuritis, it's highly unlikely that the patient will develop another attack. It could be, but usually, if MS is not going to, the physical signs observed in MS are defined by anatomical site of demyelination. What does this mean? Now, MS can very wide range of sites, central nervous system, and so forth. The manifestation will correlate with the anatomic site of the injury, of the myelinated injury. Say perhaps demyelination occurs in the primary motor cortex. This means that paralysis or in the face or weakness perhaps will be manifestation of the myelinating injury or the attack. Now if it's in sensory cortex, the numbness, anesthesia will result from the attack. Brain lesions will usually lead to either hemiparesis or paraparesis, paraplegia, and usually it injures cranial nerves, neurons. So you may have 3 cranial nerve paralysis or palsy, 6 cranial nerve palsy. You may have something that is called nuclear ophthalmoplegia, which means that the affected eye can't look ideally. Another injury that happens, which results in optic neuritis that can be only manifested as an afferent pupillary deficit, which means that the pupil will not be reacting